is a good therapy, but it's expensive and difficult to follow up the patient. Usually, patient better treated with HCG and FSH. And as we mentioned before, also testicular volume is a very important in the prognostic factor. Dopamine is used for hyperprolactinemia, and testosterone is contraindicated if you are looking for fertility. ASRM and AUA guidelines also have mentioned the same principles. So now we have spoken about the remove fertility damaging drugs and habits, specific treatment, mainly endocrinopathy, the non-specific treatment, empiric, what we call it empiric treatment, because there is why we use empiric treatment in this time of evidence-based medicine, simply because the problem that many of our patients that we don't have a proper diagnosis, we cannot reach a clear diagnosis. This ranges in the literature between up to 30–40%, reaching up to 75%. So if we don't know the real underlying cause, usually the treatment will be empiric. So the endocrine empiric therapy, as we mentioned, will divide endocrine and antioxidant. Endocrine empiric therapy includes selective estrogen receptor modulators, or which include the clomiphene and tamoxifen, aromatase inhibitors, gonadotropin-releasing hormone agonists, and as we mentioned, all these are non-FDA approved medications. Why? So it is important to differentiate before you start these patients. This is very important because literature is very clear about this. Patient who's having normal gonadotropic eugonadism or hypogonadism, then patient who's having hypergonadotropic eugonadism or hypogonadism. So if the FSH is normal, and here normal we consider it up to 8 or 9, or patient who's having high FSH, because the treatment based on the guideline that I'm going to show you later on is completely different. And the aim of treatment in these groups can be either azoospermic or severe oligospermic. And what I'm aiming here either to improve the semen quality and hoping that this will be reflected into a more improved spontaneous pregnancy, or at least improve the ART outcomes, including IUI or X. So the rationale why we do that, because there is a state called relative hypogonadism. That means that these patients might having normal FSH, low normal or normal testosterone, but these levels are not functionally enough working into the Sertoli cells and the Leydig cells to produce spermatogenesis. So improving the endocrine nature within the testis can be reflected into the spermatogenesis. And also, if you look into why male and female, like in females, she's completely normal and she's trying to induce pregnancy. So usually the gynecologists, what they do, they will give ovulation induction, whether within an ART procedure or naturally they are trying to improve. And this is the same concept can be applied here. So I cannot understand or comprehend why this is normal in females. When we use that in males, it's considered abnormal. It is the same principle. It is the same hypothalamic pituitary gonadal axis. So the first one and the most commonly used one is the selective estrogen receptor modulator. And the main mechanism of action here is blockage of estradiol, negative effect on the pituitary glands and in the hypothalamus. And when you remove this, you expect that the hypothalamus produce more GnRH, pituitary produce more LH and FSH, and this will be reflected into a better spermatogenesis. These include indication. Usually we give them in, as we mentioned, idiopathic oligo or low with low or low normal testosterone. And agent include clomiphene citrate, which is usually given either 25 milligram once daily or 50 milligram every other day. Tamoxifen citrate is usually given 10 milligram BOBID. It is very important to know that this medication is not without side effects. Some of them are very, very serious. One of them is the idiosyncratic decrease in semen count. And this is very sensitive because patient coming with fertility, when you give him medication, and these medication can lead to further drop in their semen count, even though that this is not very common. It's only 5%. It's very, very important to counsel the patient that this risk is already there before you embark and starting these medication. The second most common and very serious side effects is the hypercoagulable states. And I have seen patients that develop DVT, patients that they have developed pulmonary embolism on these kind of medication. So make sure that patient who's having really low testosterone and normal FSH is the better, and counsel the patient about these medications. The other are not very common, are not very serious, like weight gain, hot flashes, mood swings, gynecomastia, nausea and vomiting. So these are the most common side effects. Looking into what the literature says about these medication, this is one of the literature meta-analysis that has been published in 2013 in Andrology and included 11 randomized controlled study of a good methodological quality were included in this meta-analysis, and it has shown that pregnancy rate improved, sperm concentration improved, sperm motility improved. There was elevation of FSH, which is reflected into elevation also, improvement of spermatogenesis, as mentioned earlier, and improved testosterone production. Another study, more recent one, published in 2019, also a meta-analysis. And meta-analysis and studies are considered one of the highest rank on evidence of treatment. Also published in expert opinion, included 16 controlled and non-controlled trials. 11 of them was randomized controlled trials, and have shown that there is increase in pregnancy rate, sperm concentration, total sperm count, improvement in LH, FSH, and total testosterone. So if we have this kind of data, why still it is not FDA approved or still not? Because actually the problem here is the quality of these papers. Like the male fertility is huge, and inclusion criteria, exclusion criteria, having controls, having proper designed studies is very difficult. So these studies will be very inhomogeneous. So that's make these studies qualities or level of quality is low. And also the rate of, as I mentioned, the complication rate was not properly mentioned in this study. So that's why we came with a conclusion in this class of medication that there may be a subpopulation of oligospermic patients without other correctable problems that will benefit from this empiric treatment. However, further properly designed and powered studies are needed to satisfy these populations.
Dr. Haitham, you have five minutes more, huh?
I'll try to rush, but it's okay. I'll try to. Aromatase inhibitor is another way. Aromatase inhibitor is a cytochrome B450. It's usually present testes, prostate, brain, bone, and adipose tissue. Its main function is conversion of testosterone and androstenedione into estradiol, and this estradiol, as we mentioned earlier, can lead to negative feedback on the hypothalamus. Aromatase inhibitor usually can be either steroidal or non-steroidal. Studies also same thing. There are some studies with the effect of the showing the effect that positive effect of the aromatase inhibitor on all semen parameters, including sperm concentration, count, motility, and improvement in testosterone to estradiol ratio. This is one of these studies published in 2020, also a systematic review and meta-analysis. So the same conclusion that we reached there. We have studies, we have some power studies, but these studies quality is still not good enough. So also there are some group of population that can benefit from these kind of medication. Gonadotropins is also another thing, and also studies have shown that it can improve. And here I'm talking still about patients with normogonadotropic normogonadism. This is a question review that showed improvement of spontaneous pregnancy and live birth rate in patients using FSH treatment with normogonadotropic eugonadism. Another also study in 2015 by Dr. Santi have shown the same thing, and improvement of spontaneous pregnancy and pregnancy after ART. Also, the dose of using of these medications can make difference. The studies have shown that the higher the dose of FSH that you can give, the better the outcome on sperm count and motility, sperm concentration. Also improves spontaneous pregnancy. The higher the dose, the better the dose. The spontaneous pregnancy, also the ART outcomes, the higher the dose, and the dose that we usually give, as I mentioned, is 150 international unit 3 times a week. So this is the higher the dose is, the better the outcome. It can also improve the also this is the same thing, that the higher the dose, the better the outcome. So just to not waste time. This is another similar study showing the same effect. Also, it can improve the sperm DNA fragmentation. Studies have shown that patient who's having using FSH can improve sperm DNA fragmentation. Another study. So there is a lot of data around FSH, especially in the male infertility, and we will see that this led to having FSH being part of now the guidelines in the treatment of male infertility. So another group which is more difficult is the hypergonadotrophic hypoegonadism, and in this is a very controversial. So some people say don't use the SERM because actually in this group of patients, the receptors are already hypersensitive. They are producing very high, so the receptor sometimes is not working enough. So some people are saying better to use gonadotropin in these kind of patients. Uh, so now I will be speaking about the role of endocrine empiric therapy before surgical sperm retrieval. And in this review study done by Colby in 2021, including 1,132 patients, showed that improvement, patients with having normal testosterone have better chances of sperm retrieval. Another study by Dr. Hussein from Egypt also looked into the patient who received hormonal stimulation, and surgical sperm retrieval was higher in patient who's having stimulated 57% compared to 33% to patient who did not receive treatment, and up to around 11% of these patients had sperm in their ejaculate and they avoided to have testicular sperm extraction. And FSH treatment and HCG treatment was even in difficult patient reached significantly level of achieving sperms in their TC compared even in the very difficult cases. So another one rule of the hormonal therapy before surgical sperm retrieval, this is very interesting because this is the basis why it is not given. So this is a review studies published in 2022, including 22 studies. Initial surgical sperm retrieval was higher in the patient who received treatment comparing to patient who did not receive treatment. But when we segregate patient who's normal gonadotropic from patient with hypergonadotropic, we found that the patient with hypergonadotropic, the level of there was no statistical significant difference in sperm retrieval rate between patient who received stimulation than patient who did not receive stimulation. So patient with hypergonadotropic is very, we should be very cautious before we start treatment.
Dr. Haitham, 1 minute to conclude.
Okay, so just to another reason, patient with Klinefelter, it's better to give treatment with anastrozole. They will have the best option. And patient with previous failure of XC, micro TC, FSH and FSH, few studies have shown improvement. Also, this is a study done by us, looked into the different reasons of why to find sperms. There is no clear indication, but most of them, the patient that they found sperms used hormonal treatment. And this is the guidelines mentioning the same thing. Oxidative stress is another important factor. I cannot go through all the details, but it's well known that it has physiological factor and non-physiological factor. It's important to maintain the balance. As a group, we looked into the rule of these. These are the different kinds of medication that we can prescribe. And this is the global survey that has been done by the GAF team. It looked to the majority of physicians. Really, as Dr. Hamad mentioned, around 41 and 43% usually prescribe antioxidant for male infertility. And to try to look into these cases, we done some studies looking, validated a new machine called ORB, and we looked into we were able to segregate between normal and abnormal fertile patient based on the level of the ORB with 1.38, and then we had done another study, looked into the effect of antioxidant on the treatment of male infertility using a specific combination of antioxidant, and we find that there is improvement of concentration, motility, and abnormal forms, and DNA fragmentation. And finally, this is why the study. So this is the most recent antioxidant male antioxidant for male infertility. This is a systematic review, meta-analysis, question database, and looked into 90 studies, as Dr. Hamad mentioned. So they are saying that there is increased live birth, and there are some increase in clinical pregnancy. But when you look into the quality of these papers, they are very, very low quality. So I cannot say, I agree totally with Dr. Hamad that these patients, this category of medication might have some role in some patients, but we cannot define which patient exactly. And this needs a more specific and more detailed studies that can segregate who will really benefit from these medication. They are still not approved as a guideline, as a part of the treatment of male infertility. Key points is a summary of what I have mentioned before. And I think by this I can conclude my presentation. Thank you so much.